Something is
Am I audible?
Audible. Go ahead.
Good afternoon, everyone. I welcome you all to the series of webinars in interventional radiology conducted by the Department of Radiodiagnosis, KSHEMA Medical Academy, with today's subject discussion matter being on management of hemoptysis by intervention by Dr. Lennon D'Souza, sir, who's an assistant professor and unit chief of endovascular and interventional radiology at Father Muller Medical College. I kindly request Dr. Allen, sir, to introduce the speaker.
On behalf of the Department of Radiology, KSHEMA Medical Academy, I consider it an honor and privilege to welcome Dr. Lennon D'Souza to our talk. Dr. Lennon is the Unit Chief and Head of Interventional Radiology at Father Muller's Medical College Hospital, Mangalore. He secured the first track in radiology from the Rajiv Gandhi University of Health Sciences and also the gold medal from the same university. After this, he went to Bombay to the prestigious KM Hospital to pursue his fellowship in interventional radiology. I welcome you, sir, and without much further ado, I hand over the mic to Dr. Lennon D'Souza. Over to you, Dr. Lennon.
Good afternoon, everybody. Good afternoon, Dr. Allen. Thank you for that kind introduction. I hope I'm audible.
Yes.
You're audible, Lennon. Yes, clear.
All right. So the talk for today is on hemoptysis. How does interventional radiology play a role in hemoptysis, especially massive hemoptysis? And our main concern when a patient comes to the hospital with massive hemoptysis, often in the emergency setting, is basically ABC, which is airway, breathing, and circulation. And while that is important, it's very, very important to secure the airway and to ensure that the patient is breathing so that the patient can continue to be alive. We often have to stop the bleeding so that the patient does not aspirate or does not die from blood loss. So they're going to talk about the topic that is bronchial artery embolization in particular, and also I'll show a few other cases where they were not responsible as well. To talk about the bronchial circulation, to talk about bronchial artery embolization, the indications of the procedure, and complications of the procedure as well. So we have two circulations in the lung, which one is the bronchial circulation and the pulmonary circulation. The bronchial circulation is the predominant circulation. But the bronchial circulation arises from the aorta and is part of the systemic circulation. And this receives 2% of the left ventricular output. So when we talk about the anatomy of the bronchial circulation, what we need to understand is that its anatomy is very, very variable, whether in terms of origin, branching, or course. And generally they arise as a pair or as a common trunk from the descending thoracic aorta, which generally comes beyond the left subclavian artery. And most of the time, this is at the T5, T6 level. And I want you to remember this point is that it's very, very close to the left main bronchus. So all of us radiologists, pulmonologists who are out there, this is a very, very important pointer that the origin of the bronchial artery is often near the left main bronchus. So even when you read your CT scans, if you search near the left main bronchus, you will invariably find the bronchial artery. So here, this is an example of a bronchial artery. If you look carefully at this image here, this is actually, this is a digital subtraction angiography image. That's why everything looks white. But if you look through and through the image, you'll notice that this is the left main bronchus. My catheter is here near the left main bronchus, and this is the origin of the bronchial artery. And you can see this abnormal blush here in the right upper lobe, which stands for the abnormal part of the lung, which is supplied by these bronchial arteries. And as you notice here, it's very, very close to the left main bronchus. So I told you it can either arise as a single trunk or as a common trunk. So this is an example of, again, near the left main bronchus, you can see a common trunk of the bronchial artery, and here it's giving rise to the left bronchial artery, and here giving rise to the right bronchial artery. So this is where it can arise as a common trunk. Now, when we talk about the normal anatomy and variations, now this is mainly for academic purposes, where there can be multiple branching patterns of the bronchial artery. For example, in type 1, there can be one bronchial artery, and this generally arises from the intercostal artery. So this is known as an intercostal bronchial trunk. And in the same type 1, there can be two left bronchial arteries. So similarly, there's type 1, there's type 2, there's type 3, there's type 4. What's important to note is that there can be these many bronchial arteries, and often it should not preclude our search for bronchial arteries. But very, very importantly, if we do a very, very good preoperative CT scan, we are able to identify all these arteries, and we know each and every one and what needs to be embolized. If the bronchial artery now arises outside the levels of T5 and T6, now these are known as anomalous bronchial arteries. So in anomalous bronchial arteries, this can arise anywhere from the aortic arch, the internal mammary artery, the thyrocervical trunk, the subclavian artery, the costocervical trunk, the pericardiophrenik artery, or the inferior phrenic artery. So this is an example of a bronchial artery arising from the innominate artery. This is a branch arising from aorta. As you can see, this is leading into the carotid, and this is the subclavian artery. So this is the innominate artery, and here you can see a bronchial artery arising from the innominate artery. So this is a slightly more magnified image where you can recognize the bronchial artery from the innominate artery. Similarly, this is a bronchial artery which is arising from a supreme intercostal artery. So you can see the course, you can see the course of the intercostal artery here going along the undersurface of the rib, and you can see from this artery, you can see a bronchial artery arising. How we know it's a bronchial artery is because it follows the course of a bronchus. So that's a very, very, very important point for us to understand, that if an artery is not following the course of the bronchus, it's a systemic artery, which may go to the lung as well. But to be called a bronchial artery, it must follow the course of the bronchus. Now, this is an example. This is actually a subclavian angiogram, and here you can see the internal mammary artery on the right side and the bronchial artery arising from the right internal mammary artery. So this is on further probing, and here you can see the internal mammary artery is selectively hooked, and you can see the bronchial artery supplying this bronchiectasis down here. So apart from this, what's an important consideration when doing the bronchial artery embolization is the consideration to the arterial supply of the spinal cord. So the most important vessel of this is the anterior spinal artery. And why is it's important is because it receives contributions from the anterior radicular medullary branches of the intercostal and the lumbar arteries. So in case of bronchial artery embolization, when we are worried about the lungs, we are most worried about the intercostal arteries. Because as I mentioned earlier, very, very often from the right bronchial artery, you can have an intercostal bronchial trunk. And so the anterior spinal artery can occasionally arise from these ICBTs. So the most important branch of this anterior spinal artery, the largest anterior medullary branch, is the artery of Adamkiewicz. Now, most of the time, it has a very, very variable level. It can arise most of the time between T8 to L1, and most of the time they come from the right side. So what we need to know is, because they can be a variable origin from T5 to L5, our bronchial arteries are usually found at the level of T5 to T6. So it can arise from the bronchial arteries. The left bronchial arteries very, very rarely contribute to the anterior spinal artery. So this is how the artery of Adamkiewicz looks. This is an illustration where you can see this classical hairpin curve of the artery of Adamkiewicz, and this is the angiogram where you can notice the hairpin curve. So often it can be very, very faint. So whether it's the interventional radiologist, whether it's often someone who's assisting him, or often a radiology postgraduate or a medical student, whoever's around, should keep their eyes very, very wide open for this very, very important branch, that is the artery of Adamkiewicz. So always, always, always pay attention to it, and that's why I put it in red. Pay attention to the artery of Adamkiewicz. So bronchial artery embolization per se is a minimally invasive alternative to surgery, where we selectively catheterize and we embolize these abnormal vessels. Our main intention is to stop bleeding. We often cannot treat the underlying pathology. most of the time, especially in our country, what we need to understand is tuberculosis and bronchitis are very, very, very common. And these often give result to hemoptysis. Now, in these cases, most of the time, the abnormalities could be bilateral. So again, surgery may be a very, very, very difficult option. Surgery can be a very good option if it's localized to a very a small segment, and if the rest of the lungs are normal. But often when abnormalities are diffuse and bilateral, bronchial artery embolization can be the only salvage. But why I stress on the point that it's important to stop bleeding is because often the underlying etiology must be treated. If it's bronchitis, especially if it's active infective bronchitis, it needs to be treated with antibiotics. If it's tuberculosis, they need ATT. If it's malignancy, they need chemotherapy. But often this is a bridge to stop bleeding and to continue other definitive therapy. So bronchial artery embolization was first described in 1973. Most of the time, it is known to be a temporizing measure, although in some cases, they're found to have definitive effects on stopping hemoptysis. And in almost all patients, there's immediate control between 57 to 100%, depending on the selection of the patient and different other criteria. There is definite stopping of bleeding in these patients. So bronchial artery embolization in India started in the 1990s at the hospital where I trained, that is King Edward Memorial Hospital in Bombay, also called Mumbai now. And this is where the procedure first began in India. And back in the 90s itself, there was a very, very large publication in radiology's largest journal. It's a journal called Radiology, on the experience of bronchial artery embolization in KEM hospital. So the indications is often the failure of conservative or bronchoscopic treatment to control bleeding. And generally it's taken up on an emergency basis, especially when hemoptysis is between 250 to 500 cc in 24 hours. The causes may be varied. It can be infections, for example, like I mentioned, tuberculosis, bronchitis, neoplasms, vascular abnormalities, vasculitis, and also different coagulopathies also can result in hemoptysis. So before we start our procedure, what we need to remember is that we have to perform a brief neurological exam. It's important to establish a baseline, especially make the patient wiggle their toes, move their legs, because as I mentioned to you, the artery of Adamkiewicz often arises from the intercostal bronchial trunk. And if this happens, and if the patient cannot move their feet post-procedure, we need to understand. So if the patient is paraplegic to begin with, or cannot move their feet right in the beginning, then you've already established a baseline rather than panicking later. So before performing the procedure, always establish a baseline. Sometimes it may not be practical, especially if the patient had a massive hemoptysis, has aspirated and has been ventilated, and you can't perform it. But then at least we can check the planters and we can do a brief neurological exam. We often go through the femoral route and previously even through the brachial route, but nowadays we're trying to be more and more minimally invasive, hopefully get the patient back on their feet, and even a radial route to perform bronchial artery embolization is a very, very good alternative. When we do the procedure, we must always keep vitals monitored, especially the saturation. Sedation can be optional. I often prefer performing the procedure under general anesthesia because it gives me greater control, and also with regard to respiration, breath hold, because often these patients cannot breath hold very, very well. And on the cath lab table, we can perform a preliminary descending thoracic aortogram as a roadmap to bronchial arteries. But again, this is on an emergency basis. If we still have some amount of time, I would still suggest performing a CT scan in advance to map out the bronchial arteries. So always pay attention to these first few salient features, especially the point where you need a brief neurological exam. So it's also important to opacify both the bronchial arteries and the non-bronchial systemic arteries. Now, the bronchial arteries may arise from the systemic arteries, but I told you the way to differentiate between the two is to see if the artery follows the course of the bronchus. So apart from performing the regular angiograms where we already located the bronchial arteries, It's very, very important to also do selective intercostal artery angiograms, subclavian artery angiograms, internal mammary artery angiograms, intercostal bronchial trunk artery angiograms, and even inferior phrenic arteries, because depending on the location of the pathology, systemic arteries may supply the abnormal lung. So like I mentioned to you, often we have to search near the left main bronchus. This is a CT scan where it's seen very, very clearly, where we have the right bronchial artery arising from the aorta. Here you can see this is the left main bronchus on the CT scan, and you can see it's rather directed anterolaterally. This is anterior and this is posterior, and so this is anterolaterally directed. And on the left, this is the left bronchial artery where this is coming slightly more anterior. So this is just for understanding, although the clock positions may vary and can be seen better on a CT scan, but you can notice here that the right is often anterolateral and the left is more anterior. So like I told you, the bronchial arteries often, they course towards the main stem bronchi. They can go towards the hilum, go towards the main stem bronchi, and then they supply the lung. Okay. And then you can notice here, this is going along the course of the bronchus. This is going along the course of the bronchus and then supplying the lung. And as you can see here, these are the intercostal arteries. So this is the intercostal bronchial trunk. And the intercostal arteries, you can see they have an initial cephalic course, and then they run along the undersurface of the rib. So this is how you differentiate between the intercostal arteries and the bronchial arteries. So often the embolizing agents that we use here are polyvinyl alcohol particles, also known as PVA particles. So this is a plastic-like material, but they are very, very finely powdered to the tune of 355 to 500 microgram, and often 500 to 700 microgram in size. And so we use such fine particles to go into the lung blush and embolize them. It's very, very important that we can reach as distal as possible. So we use very, very fine particles, because the more proximal you embolize, you can have collaterals supplying the same lung again. So we want to make sure that we take care of the lung blush as much as possible. Apart from that, we can also use things like embospheres, triacyl gelatin microspheres. In KEM hospital, especially when a patient had no money, we would use gel foam. Gel foam is as inexpensive as 200 rupees. And we can go in with slurry or pledgets to go and embolize these things. And that's how inexpensive this procedure can be and how life-saving it can be at such a low cost. And that is why it's very, very important for us to know, especially in our context where tuberculosis is so rampant and bronchiectasis is so common, that bleeding can happen very, very often. And performing a bronchial artery embolization can really, really help save these patients. We generally avoid using coils or plugs, but often if there are very large fistula or bronchial artery aneurysms, we may have to occasionally use a coil. Again, we use them as distal as possible, but we try to make sure that we embolize the blush first, the abnormal blush with particles, preferably. Nowadays, there are more studies using N-butyl cyanoacrylate, which is also glue, although this is a little debatable, and I'll talk about it later. So the catheters that we use can either look like this. That is, the one on top is a reverse curve catheter known as a Simmons catheter, and otherwise forward-looking catheters like the catheter at the bottom, and that's known as a Cobra catheter. So these are very, very commonly used catheters. We often use 4 or 5 French catheters. And what's very, very important is, again, no matter what the size of the catheter used, we try to be as selective as possible. Of course, sometimes when there are cost constraints, that may not be possible. But as far as possible, we try to be as selective as possible, using a microcatheter, going as distal as possible to perform as wonderful a job as possible. We tried, again, as I mentioned earlier, we try to embolize as distal as possible, because proximal embolization may only cause temporary relief. So we avoid using particles which are less than 200 micron because it can cause tissue infarction. The fact that liquid embolic agent should be avoided is, again, debatable. And many centers in India are now performing this with very, very good results. So this is an example of what are the abnormal findings that you can get when you perform a bronchial artery angiogram. I've shown you this image earlier, where you can see that this is the right bronchial artery, and you can see a large blush here. If you notice this bronchial artery by itself, you can notice that it's very, very large. It's very, very tortuous. So remember, that's point number one, that the bronchial artery, when to identify that it's abnormal, it's much larger in caliber, it's a lot more tortuous. So that's point number one. Point number two is that you can see an abnormal blush in the lung. So that's point number two. Point number three, in this very image, you can notice that apart from the blush, you can see another vessel here. And that's a fistula with the pulmonary circulation. And so that's point number three, that you can get fistulae with the pulmonary circulation as well. So that's 3 points in one image. That is an enlarged, dilated, tortuous bronchial artery, an abnormal blush within the lung, a fistula. And in this image, if you notice, this is again a bronchial artery angiogram. And you can notice that you can see that there is some active bleeding. You can see a small aneurysm. That's a bronchial aneurysm with some active extravasation here. And that's the final point that you can get. That's point number 4. Although this finding is very, very, very rarely found. So these 3 points that you found here are almost always invariably found in most patients who have abnormal lungs who present with hemoptysis. So this is what the imaging looks like pre and post embolization. So if you notice here, I told you about the dilated artery, the blush and the fistula. And this is post procedure. You can see complete disappearance of the blush. And here the embolization was performed going selectively into the top branch of the bronchial artery and the bottom branch. And here you can see almost everything distally has been embolized very well, and the blush has disappeared and no fistula can be visualized. So this is again a case where you can see dilated and tortuous bronchial arteries. You can see how this abnormal blush looks. And also here you can see a small bronchial aneurysm as well. And this is post-embolization where there is complete disappearance of this blush. So again, what I'd like you to notice here is that you can sometimes get these large intercostal arteries, and here you can see there's a small radicular branch here, which ultimately went and supplied the anterior spinal artery. So here we have 2 options. One is to defer embolization altogether, especially if cost is a constraint. But if cost is not a constraint, we often go ahead with microcatheters. Again, in this case, we went ahead with the microcatheter, went as distal as possible, and then this was selected and then embolized, and you can see the complete disappearance of the blush here. So our idea is not to make the bronchial arteries disappear, but our idea is to take care of this abnormal blush. So we go as distal as possible to make sure that the blush disappears. We do not want the bronchial artery per se to disappear. So the success rates of the procedure may be anywhere between 64 to 100%. Sometimes you can get recurrent non-massive bleeding in 16 to 45%, although these are very, very old figures, and now the success rates are much higher with improvements in the PVA particles, the microcatheters, which we can use to go as distal as possible. So recurrence mainly is because of incomplete embolization, or if ultimately these arteries, especially if you use a temporary agent like gel foam, these arteries can recanalize. PVA, although it's known to be a permanent embolizing agent, is not a permanent embolizing agent. This too can recanalize 6 months down the line. So it's very, very important to counsel these patients, telling them that they may have to come back in to do another procedure in the future, especially if their underlying disease is not under control, and these vessels can recanalize. So it's very, very important to counsel them that way. And also sometimes they can be non-bronchial systemic arteries, especially if they haven't been identified. And also once the bronchial arteries are embolized, if there are collateral vessels that have developed in response to continued pulmonary inflammation, this too can lead to the presence of non-massive bleeding. And technical failure can happen, especially when you have not identified these non-bronchial artery collaterals from the systemic arteries. So when we talk about non-bronchial systemic arteries, I told you right in the beginning that we do a check everywhere. That is in the subclavian artery, in the internal mammary artery. We try to go down to the inferior phrenic artery, in most of the intercostal arteries. We even try to take a pictal angiogram run. But often what I think is a very, very good clue is that if you've done a preoperative CT scan and you find some amount of pleural thickening, then most of the times these may be supplied by non-bronchial systemic arteries. So always suspect that there may be a non-bronchial systemic artery when you find pleural thickening. So our search must be even more definitive when we find some pleural thickening present. So this is an example of a 34-year-old male with tuberculosis, and this is the left subclavian artery. And you can see beyond the left subclavian is the axillary artery. And here you can see I've selectively cannulated this vessel here with a catheter. And so this is around the axillary artery, and this is the lateral thoracic artery. And you can see a blush being supplied by the lateral thoracic artery here. And that is the feeding artery. So it's because we did this selective angiogram, we found this, and we were able to embolize this. So here you can see there is disappearance of the blush post-embolization. Similarly, in the same patient, you can see here that even the internal mammary artery on the left side has been cannulated, and this is supplying this abnormal blush, and this was embolized. So this is a case where it was supplied by 2 non-bronchial systemic arteries, and it's only when you do a very, very thorough check can you be quite sure that these are supplied by these arteries. Now, apart from doing the bronchial arteries and the systemic circulation, we must always keep a very, very open mind to other vessels which may cause bleeding. So this is a case of a 23-year-old medical student who presented with ground glass opacity in the right lower lobe. He had come with massive hemoptysis. In fact, he had come with small amounts of hemoptysis initially, and then came with a large amount of hemoptysis. And on the CT scan, we found good amount of ground glass opacity. If you look at his opposite lung, you can notice that there's an area which is hyperlucent, and it's actually enveloped by its own pleura. This is a case of sequestration. And on the opposite side, you can notice this ground glass opacity. And on the CT scan, you can see that from the abdominal aorta, you can see 2 systemic arteries supplying these 2 lobes. Now, the sequestration was not, had no ground glass opacity and did not bleed. So this was kept on check for the future, but definitely the right side, which is supplying this ground glass opacity on the right side, definitely had to be embolized. Or he had, and why this was tricky is because this is not enveloped by its own pleura. So performing surgery for him would be a very, very difficult option, considering that this is just supplying normal lung. And apart from this ground glass opacity, it's normal. Whereas the opposite side, probably surgery could be considered gold standard. But in this case, since it was a normal lung, this was preferably tackled with embolization. So again, this is actually a pulmonary artery angiogram, and you can notice in the delayed phases, this is an aortogram, and the aortogram you can see is supplied very nicely by the systemic arteries from the abdominal aorta, especially here in the right lower lobe. And now this has been selectively cannulated, and you can see this abnormal blush here drained again by the pulmonary circulation. Now we went into this and we deployed a vascular plug. So this is what the vascular plug looks like. You can see the vascular plug here, this deployed, and then about 10 to 15 minutes later, you can see that there is no supply to this. He was on 3-year follow-up with us and developed no further episodes of hemoptysis. He's now pursuing his PG elsewhere, and so currently we don't have follow-up of him. But until the course of his medical, until the course of his MBBS, he had no further episodes of bleeding. So now when we talk about the complications of the procedure, like I mentioned to previously, we're very, very wary of the artery of Adamkiewicz. And if this is inadvertently embolized, it may result in transverse myelitis. So this is often due to non-target occlusion. So if the anterior spinal artery is arising and it was not recognized, it could result in this. And often when we recognize it, either we do one of 2 things: is either we defer the embolization or we go distal to it, as distal as possible into the blush, very, very carefully perform the bronchial artery embolization so as to not cause any reflux of embolic agents and not cause this complication. So always, always, always pay attention to the anterior spinal artery, to the artery of Adamkiewicz, and try and recognize the hairpin curve of the artery of Adamkiewicz. Other complications can be chest pain, often because the intercostal arteries are embolized. So along the course of the intercostal artery, there may be some amount of chest pain, which is self-limiting. If there is non-target embolization of some esophageal branches, occasionally there can be dysphagia. Again, this is very, very uncommon. And the other complications are even rarer. I personally have not seen any of the rarer complications, that is aortic or bronchial necrosis or a bronchioesophageal fistula or non-target embolization. And I'd like to believe I have quite a vast experience with bronchial artery embolization, and I have not seen these complications so far. So I'd like to conclude my talk by talking about how bronchial artery has really, really revolutionized the treatment and approach to hemoptysis, especially because we have very, very high rates of immediate clinical success with very, very low complication rates. So apart from the very, very low complication rate, the only thing that we really, really need to be wary of is the arterial supply to the spine. So be very, very careful. I keep reiterating this and repeating this, is try and identify the hairpin hook shape of the artery of Adamkiewicz and try to avoid embolizing or go as distal as possible and try to avoid having reflux into this vessel. We always should keep in mind that surgery is a very, very good alternative, especially when the pathology is restricted to a particular lobe or a segment, or if for some reason embolization is not possible because of a technical difficulty or in case of embolization failure. But often we do not get this scenario in India, especially because abnormalities are often bilateral and diffuse. So apart from these reasons, bronchial artery should be considered a mainstay for the treatment of hemoptysis. Thank you. I'd like to take any questions if anyone has any.
We are open to questions which can be placed in the chat box. I didn't receive any questions as of yet, sir.
No problem. I try to keep the talk as short as possible and directed more towards the postgraduates. And that's why I was able to wind up in about 25 minutes or so. So
most of them will be watching it offline. Questions might be coming later.
okay.
There's a question. The viewer is asking what type about bronchitis venous.
I'm sorry, what was that again?
Not very sure what it means, sir. A viewer has asked, what about bronchitis venous?
I don't know whether they're asking about bronchial veins.
Probably so, yeah.
I do not know what bronchitis venous means. I'm assuming whether they're asking about bronchial veins. So, I mean, bronchial veins can often just return blood from the bronchi, but these do not contribute to bleeding in any case, if you're asking me about bronchial veins. And often they don't have to be accessed. And either way, if you're accessing the bronchial arteries and we're embolizing them, then the bronchial veins are usually of no large concern. Because often when we worry about hemoptysis, especially massive hemoptysis, it's usually an arterial source that we're worried about.
Thank you, sir, for the wonderful talk. Now I request Alan, sir, to give a vote of thanks.
On behalf of the Department of Radiology, KSHEMA Medical Academy, I thank Dr. Lennon for his wonderful talk on interventional radiology. He has spoken about hitherto unknown aspects of interventional radiology, and I'm sure our PG students would have benefited from his talk. Thank you, Dr. Lennon.
Thank you, Doctor.
I thank our Dean, Dr. P.S. Prakash, for his valuable support. I thank our IT department staff for their technical support. I also thank our departmental staff and our HOD, Dr. Raghuraj, for their valuable support and guidance. Last but not the least, I thank our PG students and delegates who have attended this seminar and made it a success. Thank you one and all.
Raghunath sir, do you want to add anything?
Yeah, nothing, Manu. I think you can wind up. It's a wonderful talk. I thank our Lennon sir again for this wonderful talk.
Thank you, Alan sir. Thank you, Raghunath sir. Thank you, Lennon sir, for the wonderful talk.
Okay. Thank you for having me.
Close the session.